Cancer is such a complex disease. We have 350, 400 different kinds of cancer. 10 to 15% of all cancer patients will actually have a gene defect that makes them vulnerable to get different cancers. I often have patients in my clinic where we have unfortunately diagnosed a cancer, and the common comment is, nobody in my family had a cancer. My parents didn't have it. My grandparents never had it. So how can I have cancer? Because it runs in families. For example, a lot of the audience would know about Angelina Jolie. Her mother had a BRCA1 gene mutation. She tested herself and they realized that she was also carrying this defective gene, which made her prone to get cancer. When you look at mortality because of cervical cancer, the mortality has actually reduced dramatically. And then when you go into the reasons as to why that mortality reduced, was it because of the advances in the treatment? The answer is no. Their mortality reduced because they looked at screening. 50% of all cancers may be attributable to a bad lifestyle.
A cancer caught early goes better on treatment. Early diagnosis is the key is what I feel. A big hello to all viewers of this podcast. Welcome to our new series. Where we interact and engage with doctors of different specialties to talk about health topics and concerns which concern the normal people. So it's our quest to make healthcare more understandable. In our first episode, we'll be talking of oncology, that is about cancer diagnosis and management. For this, we have Dr. Devavrat Arya, medical oncologist, working with as Senior Director in Max Group of Hospitals. And I am Dr. Prashant Nag, your host, pathologist by qualification, Vice President Tata 1MG. So together we will navigate through the roads of oncology, we'll debunk the myths, unravel the mysteries, and we'll put some light on the newer advancements. So let's go ahead with the scene. Welcome, Dr. Devavrat, to this Our Health podcast series. Great to have you here. As you know, we are going to discuss about cancer diagnosis and management and oncology in specific, and we'll be very grateful to have your knowledge around it. I should start with the prime message, which as a doctor I feel, just going through the stats a while back, lung cancer, which is diagnosed at stage 4, has a 5-year survival rate of as poor as 5%, while a lung cancer diagnosed at stage 1 has a good 5-year survival rate of 65%. So one take-home point which I'm very clear upon is, which I feel anyone who is watching this podcast should take along is, a cancer caught early goes better on treatment. Early diagnosis is the key is what I feel. Please, your views.
So first of all, thank you for having me here. And congratulations. This is a great initiative that you're taking. Health education is very important. So when you talk about lung cancer and statistics, you've hit the nail on the head, right? Cancer is a complicated disease. It comes in different stages, and I'm sure we'll talk about this in greater detail later in the podcast. But the more advanced the stage, the more complex the treatment, lesser chances of success, which translates into lesser chances of cure. In stage 4, we are just about beginning to talk about cure, but in most cases, the survival is poor. And it's not just lung cancer. Across all cancers, higher the stage, worse the outcome.
Now, let's take to the flow and help our viewers to understand what is cancer, how it goes. So my first simple question will go this: how do you think what cancer is? And is cancer and tumor synonymous? Because we are a country plagued by Bollywood. So at times people feel that cancer and tumor are synonymous.
Human biology is very complex. Our bodies are designed in a way that there's a lot of self-repair happening. We often get injuries, especially when we were young, we would get injuries and the injury would heal up in a few days' time. And the mechanism is very intricate. The body recognizes that there's some cell damage, and then there's production of new cells. And the number of cells that are produced is very tightly regulated, not just by one system, but perhaps 2, 3, 4, 5 systems, which means that cell growth is a tightly regulated mechanism in the body. Now, because of various reasons, when these mechanisms start failing, you'll probably have a situation where the number of cells that are dividing and being produced far exceeds what's needed. When this growth is localized, cannot spread, this is what we would refer to as a tumor. In science, we have a differentiation between what is a benign tumor. A benign tumor is a tumor that is localized to the area of origin may start invading the surrounding organs, but typically will not spread. But a malignant tumor has the capability to spread either through direct invasion, through lymphatic vessels, through blood vessels to distant organs. And characteristically, those tumors which are malignant are what we refer to as cancers. And those tumors which are benign are in common parlance called tumors.
Taking our journey forward, debunking myths and unraveling the mystery of oncology. Next question is around a myth, which is around that cancer is all about inheritable genetics or genetics. So we'd like to know your view, your patient interactions, how you feel about the genetics role and the other factors which are important for cancer.
I think you've asked a great question, Prashant. We all understand that cancer is a genetic disease. But in common parlance, we have to separate the genetics, which is the common understanding of people, and the genetics that we refer to in cancer biology. I often have patients in my clinic where we have unfortunately diagnosed a cancer. And the common comment is, nobody in my family had a cancer. My parents didn't have it. My grandparents never had it. So how can I have cancer? Because it runs in families. Now that's partly correct. We know of a lot of genes that we all have. For example, BRCA gene, which is a very important gene in repair of DNA, which is the knowledge code in our cells, so to say. And any defect in the BRCA apparatus because of a mutation in that gene can make people vulnerable to different cancers. And genes like this actually run in families. For example, a lot of the audience would know about Angelina Jolie. Her mother had a BRCA1 gene mutation. She tested herself and they realized that she was also carrying this defective gene, which made her prone to get cancer. Now the question is, what is the percentage of cancer patients who are likely to have a gene defect or gene mutation that runs in the families and which makes them or their brothers or sisters or children prone to get those cancers? I think that ballpark figure is about 10-15%, which means that about 10 to 15% of all cancer patients will actually have a gene defect that makes them vulnerable to get different cancers, which also means that 85% patients do not have that gene defect.
Although there is a genetic defect which is coming, but that was not you are born with. That is something which you are acquiring. So building upon it, can you tell me how lifestyle affect cancer occurrence and what is the role of lifestyle in cancer disease?
I think lifestyle is a burning topic in oncology. We don't have estimates from India because India is being such a huge country, you will not have reliable surveys available. But from the Western data, we know that perhaps 50% of all cancers may be attributable to a bad lifestyle. Now, that's a huge number. I think one might think that we have a better lifestyle compared to, say, the lifestyle in the US. But I think in our urban centers, cities like Delhi, Bangalore, our lifestyle is very similar to what I would expect a person living in a Chicago or a New York or a London to have a lifestyle. So I think the number possibly in India is nearly 50-55%. Now, when we talk about lifestyle, there are different components of lifestyle. What is lifestyle? Is how we live life on a daily basis. Addictions is a very important component of lifestyle. Tobacco, unfortunately, is a bane for our country. Even the latest surveys suggest that as many as 15 to 25% of our population actually uses tobacco. And some estimates suggest that while India has about 14 to 18 lakh new cancer cases being diagnosed every year, about 5 to 6 lakh of these cancers happen because people are consuming tobacco, which in many ways is a preventable segment. So 6 lakh preventable cancers happening, which because people are consuming tobacco for a variety of different reasons, end up causing, which is otherwise a very, very difficult disease. We also talk about alcohol addiction. There is evidence to say that there are cancers which are related to alcohol. Breast cancer in women, which is now the top cancers when we talk about different cancers that can happen in women. Cervical cancer until a couple of decades back used to be the top cancer in women. Now it is breast cancer. Alcohol has a huge role to play. Obesity. Now, we all feel that obesity is a Western disease. I was reading a data which suggested that nearly 12 to 15% Indian population is obese. We are seeing alarming levels of obesity in the urban population. We are seeing alarming levels of obesity in our children. Our population is 3 times the population of the US. The number of cancers that are diagnosed in the US is similar to, in terms of exact numbers, is similar to our numbers here in India, which means that our per 100,000 cancer incidence is still sitting at 1/3 of their population. But the alarming thing is, when you look at urban population with a lifestyle very similar to the Western lifestyle, the numbers sit very high. Whereas when you look at the rural population, where lifestyle is still very different from the cities, the cancer incidence is lower. And I think that in itself is a clear indicator of how lifestyle impacts and how it can impact the rate of us getting cancer.
On lifestyle, see, there are habits like smoking, which we all know that it's a bad habit. But I like you to just take along the route what an active smoker gets, what packs are important, what a passive smoker get from that smoking. So if you can just elaborate around the same, because lung cancer is such a common cancer.
Smoking is bad. When you look at a cigarette smoke, there are potentially 350 different chemicals in a cigarette smoke, out of which 75 are proven carcinogen. So a carcinogen is a product. It could be a chemical, it could be a physical factor that increases the risk of cancers in humans. So a cigarette smoke has 75 different proven cancer-causing chemicals that lead to an increased risk of cancer. Now, a lot of people come to me and ask me, I just smoke a cigarette or 2 cigarettes in a day. Does it still cause harm? The answer is, there is no threshold below which smoking is safe. In fact, there's no threshold below which drinking is safe. And any amount of smoke can increase the risk of cancer. Quite obviously, the more you smoke, the heavier the history of smoking, higher the risk of cancer.
And with this pollution and all, I don't know where that threshold of cigarette smoking will go, because it is also adding to all that carcinogens.
So I think you made a great point. Air pollution is a carcinogen. In fact, recently there was a study coming out of France where they actually created or showed a clear association between higher air pollution and risk of getting breast cancer. Now, air pollution is something which may not be entirely in my hand or yours. But if you add smoking on top of it, it actually magnifies the risk of getting cancer.
Taking it further, another thing is, like you have answered very well, I'm a bit more clear about lifestyle things. How do you think age plays a role? Because at times it is a notion that cancer is an old age disease. So how do you see in different cancers that age has a role, like lifestyle has a role, how age plays a role in cancers and all?
You are right. I think as we grow older, our possibility of getting a cancer increases. And for most cancers, not all, for most cancers, the rates increase as the age of the population increases. There will be some exceptions. For example, when you talk about blood cancers, you talk about certain lymphomas, you talk about certain sarcomas, you'll see them happening in the young children, adolescents, whereas a diagnosis in the older population is a rarity. But if you talk broadly about cancers, breast cancers, cancers of the uterus, ovarian cancers, cancers of the intestine, etc., the older you are, higher the risk is of getting a cancer. And therefore, for an aging society, the challenge is, how do you keep up with the increasing number of cases that you are going to diagnose? An older patient is a more difficult patient to treat because that older patient will likely have more comorbidities. He or she may have diabetes, heart disease, kidney disease, and a treatment protocol which is typically designed for a younger cancer patient becomes more difficult to deliver in an older patient. But coming back to the point, India will eventually start having a more aged society, and therefore we are potentially looking at increasing number of cases being diagnosed every year. In fact, there is some estimate to say that the lower middle income countries will potentially have doubling of cancer diagnosis over the next 25 years because the population is going to age. So unfortunately, there's no age group which is safe from cancer. And that's a reality that we all need to understand. We have about 1 lakh cancer cases being diagnosed between the age group of 15 to 40. And those are Indian statistics. Now, this is the age group where you feel that cancer should probably not happen because you've passed childhood. So you've crossed that age of getting the childhood cancers and you're not quite old. Now, diagnosis at a younger age brings its own challenges. The other day, somebody asked me, what is the youngest breast cancer patient that you've seen? And it's a question, the answer to which was an astounding 17 years. So I had a 17-year-old patient who was diagnosed with breast cancer, the median age of which is about 45 years, 50 years. We were looking at our own data from our hospital, and particularly breast cancer, and we realized that as many as 5 to 10% of our patients were diagnosed in an age group of less than 30 to 35.
Can you please stress on how screening goes, how screening will help in it? Because what we cannot change overnight is the lifestyle, overall surroundings, pollution. Probably those are the factors which definitely we'll look at, but may not be so simple to change. I think role of screening becomes all the more important. So it will be great if we can talk about that.
So I started my oncology career about 15 years ago. And we would often go to these health camps. You would have a doctor sitting with a BP apparatus. You'll also have a second doctor who will be measuring the blood sugars. And you'll have a third doctor who comes from oncology specialty, who's willing to give advice and willing to understand if there are possible patients or people who have suspicious symptoms which might necessitate further testing. And what was astounding was that while you would have long lines in front of the BP seat, you'll have long lines of people waiting to get their sugars tested. You'd hardly have any person coming to the cancer specialist for an advice. Now, at the root of this lies our inherent feeling that I can never have it. I think that's the biggest challenge that we face in our country. Now, India has been a lot about infectious diseases. We have about 3,000, 4,000, 5,000, 50,000 dengue cases, and it captures headlines. We had COVID, which captured headlines like anything. Now, my estimate is more than double the number of people die of cancers than people who died of COVID in that unfortunate period of 3 to 4 years. And therefore, it is very important to understand that non-communicable diseases, diseases which are not related to infections, are an important component of deaths even in our country. The latest estimate suggests that 60% of deaths in India are because of heart diseases, lung diseases, diabetes, and also cancer. And I think the component of deaths being caused by cancer is steadily going to increase. And we are potentially looking at doubling of cancer-related deaths in the coming 2.5 decades. So it's very important that all of us understand that while I might not want to give this a fancy term, perhaps we are not sitting on a cancer tsunami, perhaps we are not sitting on a cancer time bomb, but we are certainly sitting on a scenario where the numbers are going to go up, where we'll have at least most of the families having one patient getting a cancer. And as urbanization increases, as our lifestyle worsens, you'll have more and more cancers being diagnosed more often in those families which so far have been untouched by cancer. Which brings us to the question that you asked about screening. Another anecdote. Cervical cancer was a major challenge for a lot of countries. And back in the early 19th century, United States, which at that time was again a very advanced country, was having difficulties treating patients with cervical cancer. They were plagued with high mortality because of cervical cancer. Now, jump to early 2000s, and we talk about advances in oncology, newer diagnostic modalities, newer treatments, newer drugs, smaller surgeries, better radiation. When you look at mortality because of cervical cancer, the mortality has actually reduced dramatically. And then when you go into the reasons as to why that mortality reduced, was it because of the advances in the treatment? The answer is no. The mortality reduced because they looked at screening and they applied universal screening. Now, in the US, for the patient or a person in the eligible age group, they'll get a mail saying that your pap smear, which is a very easy, very simple test to identify lesions which can potentially turn cancerous over the next 5, 10, 15 years. So a pap smear, you'll get a mail from the government, from the hospital, from the community center saying that your pap smear is due and you should report to a hospital to get the test done. Ours is a country of much bigger numbers. You cannot have a government-run cervical screening or cancer screening program. But yes, as a individual who is responsible for his or her own health, I am responsible for my health. I would look at whether I am a candidate to get a screening test. And if I am a candidate, I should go to the hospital and get a screening test done. Now, there are 4 or 5 screening tests that have been established as valuable. One is a mammogram. Mammogram is simply an X-ray of the breast. Any woman who's more than 50 years should get a mammogram at least once a year. The initial studies, the initial research suggested that vaccinating with a cervical cancer vaccine actually prevented 99.9% HPV associated infections, which would then mean that translates into lower risk of getting a cancer and lower cervical cancer related mortality. Now, herein lies the problem. We talk about screening and we talk about India, which is now a country of 1.4 billion, and we are increasing. And if we were to look at the number of patients who would be candidates for cervical cancer, it would easily run close to 300 or 400 million women who would be candidates of getting cervical cancer screening. And at different platforms we have discussed, is screening the only and the only right strategy for Indian population? I think what all of us realized is that we need to have our own solutions to the problems that we face. And I think targeted vaccination is something that we have to increasingly look at. The problem with vaccine so far has been the cost, because the vaccine is manufactured by multinational companies and the cost has been quite prohibitive for most of our population. And therefore, while there is an increasing awareness that the vaccine prevents cervical cancer, and I'll go on to expand that, the vaccine prevents not only cervical cancer, the vaccine can prevent cancers of the genitalia, cancers of the anal canal, which is the last part of the large intestine after the rectum, cancers of the head and neck. We have data from Europe and US saying that their cancers of the throat, the tonsils are increasing because of changing sexual practices and leading to HPV vaccination infections and leading to higher risk of head and neck cancers. And therefore, the guideline is not just to vaccinate girls. The guideline is also to vaccinate boys. And recognizing all of this, we have realized that there is a need for a lower cost vaccine, and we hope to see a rollout of a lower cost vaccine very soon. And recognizing this, in fact, recently the government of India actually incorporated cervical cancer vaccine in the universal immunization program. So I think all of this highlights that these are vaccine preventable diseases. Now, all of us hope to have one single vaccine that prevent all cancers. Unfortunately, that is not a reality now. I don't think it will be a reality ever. Cancer is such a complex disease. You have 350, 400 different kinds of cancers. You can't have a single vaccine ever that one could take and be free of this disease. There are more than 300, 350 different cancers. Each of the cancers may have a different symptom. And unfortunately, a lot of times, cancer will be associated with a usual symptom that can also be a marker of other conditions like an infection or inflammation. Now, for certain cancers like breast cancer, you have a specific symptom. If somebody has a lump in the breast, change in the skin of the breast, the color of the breast, the shape of the breast, a lump in the armpits, or a discharge, especially a clear discharge, that can be a sign of breast cancer. A lump in the breast can also happen in a man. And the unfortunate reality is that a male can also have a breast cancer. Similarly, cancers of the head and neck may be associated with an ulcer that is not healing, a swelling, a difficulty in swallowing, difficulty in breathing, change in voice, etc. A lung cancer can be associated with a new, different kind of a cough, change in voice. A patient brings out phlegm, sputum, that has blood in it, breathing issues. Bleeding from any part of the body, be it the mouth, the nose, in the urine or in stools, or bleeding in between periods for women can be a harbinger of cancer. Uh, a swelling in any part of the body, a painful swelling in any part of the body, very easy injury or a easy fracture happening in a bone could be a marker of cancers of the bone or the soft tissue. Similarly, very simple symptom like a change in bowel habit, so constipation alternating with diarrhea, could be a symptom of a colon cancer. Now, the catch is, how does a normal person remember all these symptoms and say, if I get this, I should go to a doctor? And my answer is usually a very simple answer. If anybody has any symptom which lasts for more than 2 to 3 weeks, so if someone gets a cough which is not getting better even after 2 to 3 weeks of medication, or if there is a new pain in the back, which otherwise would be controlled by simple medications like paracetamol or tramadol, but is not going away, needs stronger medications, any unusual symptom, or a symptom where the fever is not going, there is no reason why somebody is losing weight, but that person is losing weight, loss of appetite. So any such symptom or a symptom that lasts for more than 2 to 3 weeks should mean that you should go to a doctor. Now, the doctor doesn't necessarily have to be a cancer specialist, because these symptoms could be pointed towards an inflammatory disorder, a chronic infection like tuberculosis, or it could also be cancer. So it is the job of the doctor to then order the right test or refer to the right doctor and then work up accordingly.
From a diagnostician perspective, I'd like to add that when we look at the testing of cancers, we look in 4 parts. One is the tests which tell the predilection. So there are genetic markers which can tell that you may or you may not have cancer, but you are predisposed to get that cancer. So those are the germline mutations, the mutations which you are born with, what you have got from your family. So you, your sibling, your parents may or may not get affection, but yes, you are predisposed to. Then there are early screening markers. Whenever we say screening, we should understand one thing, that screening has some propensity of getting a false positive. So a screening marker is something which will try to detect all cancers, all that type of cancer for which the test is. So there are specific screening markers like PSA, which can diagnose which can detect a prostate cancer, and then we can go for biopsy and all to confirm whether cancer is there or not. And then there are tests like there are genetic tests which can detect 15 to 30 cancers at a time from a single blood test. And that is simply a hats off thing to this new discovery, where from a small, from blood itself, we take the cancer cells out, we test the genetic material on it, and if we found something which is found out of those mutations which develop cancer, and we can detect the cancer from simple blood test. That is early diagnosis. Then there are diagnostic tests. We'll definitely go deep with you while discussing further about targeted therapy and precision medicine. That is something which we'll like to cover in the later segment when we'll talk of treatment. But yes, for precision medicine, you have to have a targeted mutation to be detected. So that is diagnostic test. And then there are prognostic markers. A person having a same type of cancer, a breast cancer in one person may be more aggressive than a breast cancer in another person. And that may be detected by a type of mutation the person has. So these are the 4 types how we look at cancer. We'll love to have your view further on it.
I think you've elaborated on it very nicely. And I'll probably share my experience with how I work up a patient who has a suspected cancer who walks into my clinic. Now, to me, obviously, we've talked about predilection. We've talked about whether a test can predict that a person can have cancer or not. We'll keep that segment aside. So if a patient walks up to me with suspicious symptoms, one of the key tests that I order is a test called as a biopsy. Now, there are lots of myths around biopsy. A lot of people feel that a biopsy can actually spread the cancer, increase the stage. And this is one of the most common notions that I come across in my clinic. Most cancers, biopsy is safe. There are certain cancers where a biopsy should not be done. For example, nobody orders a biopsy for a testicular tumor. Nobody should be doing a biopsy for an ovarian cancer. Similarly, nobody should be doing a biopsy for a salivary gland cancer like a parotid cancer. But in most other cancers, a biopsy is crucial. Biopsy helps in confirming whether there is cancer or there's no cancer. Oftentimes, in a same organ, you can have different kinds of cancer. For example, lung cancer, one could think of as a single kind of cancer. But when you actually go into the pathology of lung cancer, you realize that there are 15, 20 different kinds of lung cancer. Now, they all differ in how they behave, how aggressive or non-aggressive they are, and by corollary, how I'm going to treat them, whether chemotherapy is going to be used, whether immunotherapy is going to be used, whether we should be doing surgery at all or not. So all of that is influenced. And therefore, a biopsy is supposed to provide tissue to confirm the diagnosis. A biopsy also helps me understand the subtype of the cancer. Oftentimes, when we have a confirmation of diagnosis, we want to understand the stage of the disease. And we referred to stage earlier. The earlier stage is a stage 1 or a stage 2 where a cancer is confined to the organ of origin. A stage 3 is when the cancer begins to spread out of the organ of origin, mostly to the surrounding lymph nodes. Sometimes there may be direct invasion of the surrounding organs. And stage 4 is when a cancer has spread to distant organs. And typically, depending on what cancer that we are talking about, you'd order further scans. And very often these days, one would hear about scans like PET scans, which are basically a CT scan and a FDG or a PSMA or a radio-labeled tie-enabled investigation, which helps us look at the entire body and understand the stage. So once I have a stage, that helps me decide what is the best way to treat. Now, oncology is 3 pillars. Oncology is not just the surgeon. So we have a surgeon who does cancer surgeries, and that is the doctor we refer to as a surgical oncologist. We have a radiation specialist who helps in kill of the tumor cell using radiation or X-rays, sometimes proton. And we have the medical oncologist who's somebody like me who'd use chemotherapy, immunotherapy, target therapy, antibody drug conjugates, hormone therapy, etc., etc. And these are basically medications which help in controlling the disease. Now, cure involves different mixes and matches of all these 3 modalities. There are certain cancers where you do not need all those modalities. There are certain cancers you need all modalities. Coming to the more advanced stages, we also look increasingly at the molecular profile. So we earlier discussed in the podcast that cancer is a genetic disease. And at the root of cancers are alterations in DNA, which we refer to as mutations. Some of these mutations are the processes which drive the cancer, which actually makes the tumor divide faster, grow faster. And with research, we have understood that if you can target these mutations with what we refer to as targeted therapy, you can actually control the cancer better. So there are molecular markers which may be predictive. They help me understand whether a particular target therapy can be used. They may be prognostic, where if a molecular marker is present, it may help me understand whether the cancer is likely to be more aggressive or less aggressive. And all of this is helping us bring about what we call as a personalized therapy in cancer, where we're saying instead of treating all cancers in a similar way, how do I identify different traits of individual cancers, segregate into different subgroups, treat them differently, and hopefully have different outcomes based on that treatment.
We would like to talk more about CAR T. We know that CAR T therapy is right now talked a lot about in blood cancers, where you use immune system to kill the cancer cells. So how does CAR T works when it comes to blood cancers, and why are we not exploring CAR T for non-blood cancers?
Right. So CAR T cell is a part of the whole gamut of the new field of medicine called precision medicine. And if I had to explain precision medicine in very simple words for the audiences, it's the right patient getting the right drug at the right time, at the right dose, and through the right route. So there have to be all these rights coming in. And if you have to understand precision medicine, we probably need to go back 50 years into the history of how oncology has evolved. Now, 50 years ago, the general concept was, for example, I'll quote the example of breast cancer. You do the biggest possible surgery, you achieve the highest possible cure. So for breast cancer, there was this surgery called radical mastectomy. They would remove the entire breast. They would remove the muscles in the chest wall. They'll remove all the blood vessels and the nerves. They'll remove all the lymph nodes. Now, while this surgery was a big surgery, in a lot of cases, it led to cures. They also realized that about 20-30% of women who, despite having such an extensive surgery, were still having a recurrence. And they said, okay, maybe there are some cells which through the blood circulate in the rest of the body, which over a period of time can grow back, lead to a recurrence despite a big, good surgery. And they started treating those patients with radiation therapy. Now, what radiation did was reduce the number of recurrences locally, but radiation could not prevent recurrences in distant organs. So the cancer still would come back in lungs, livers, bones, distant sites, and in most cases would not be curable. And that's when the concept of chemotherapy came in. And the initial chemotherapy regimens were with basic chemotherapy drugs, difficult drugs associated with side effects.
Primarily cytotoxic. Killing all the cells.
Right. And unfortunately, the concept of chemotherapy is that chemotherapy kills fast-growing cells. And tumor cells being the fastest-growing cells, but we have normal cells in our body, hair, our blood cells, white blood cells, platelets, intestinal cells. These are all fast-growing cells. And while they had good response, they also had high side effects. So the basic chemotherapies of 50 years ago was a year-long, 2-year-long chemotherapy. And then we realized that researchers back then realized that they could not afford the treatment to have such high side effects and such less effectiveness. And that's where I said, let's try and search molecules which are more specific, more effective in treating and are associated with lesser side effects.
They know the address where to go.
Correct. And this is an ongoing area of research. Now, while we have much safer chemotherapies now, we want them to be even safer, more effective, less toxic, less side effects. But what has happened with this advances, that the surgeon realized that a bigger surgery is no longer needed. So with the advances in the field of medical oncology, what it actually enabled the surgeon to do was to get away with doing a smaller surgery. So radical mastectomy first became modified radical mastectomy. So the surgeon no longer needed to take out the entire muscle. He could leave the muscle back. In fact, to now, where for most women, we don't even need to remove the entire breast. It's a breast conservation surgery. So the surgeon would look at the lump, remove a rim of normal tissue, and do a basic lymph node removal. And that's it. In fact, a lot of times, I would have women who have a 3 centimeter lump and who want a breast conservation surgery. In fact, we would offer chemotherapy first, shrink it down further, and a breast conservation surgery becomes feasible. And the cosmetic results of the surgery are also maintained.
Yeah, what a boon for that female. And again, that savior from those lymphedemas and those swollen arms because of those surgeries. That is a very big achievement of the medical science.
And think of sarcomas. Now, for a child who had a sarcoma of the leg or the arm, 30 years ago, it meant an amputation, period. There could be no surgery that would save the life of the patient. Now, with the advent of chemotherapy, in certain cases, radiation therapy, a conservative surgery is feasible. And if I have 100 cases at my hospital with a bone sarcoma of the limb, an amputation is needed in less than 5%. In 95%, we do what we refer to as limb preservation surgery.
Great to know. Great to know.
So the field has evolved, which means that we have now more effective chemotherapies. Obviously, chemotherapy affecting a rapid growing cell was a big disadvantage, meant that a patient would have more side effects. And that really pushed this search for not only more effective therapies, but also safer therapies. Chronic myeloid leukemia is a very slow growing blood cancer. But 30, 40 years ago, most of these patients eventually would have an acceleration of the disease, and majority of these patients needed a bone marrow transplant. In fact, for bone marrow transplants, the biggest number of candidates for chronic myeloid leukemia. Until a point where they realized that there was a gene alteration called the Philadelphia chromosome, which basically is a mutation, which led to these white blood cells dividing in an uncontrolled fashion, and which led to the search of this drug, which we refer to as imatinib, which could reverse this process and bring the disease under control. You'll not believe it. Back in the 80s, the drug actually found itself on the cover of a very reputed magazine called Time. And this, to my mind, was one of the first targeted therapies. We then had a drug called gefitinib, which was used for lung cancers which had an EGFR mutation. And this is where our thinking changed. We realized that maybe a majority of cancers have these gene alterations, which can then be reversed, at least mechanistically, and you could use targeted therapies.
Yeah. The time we passed, cancers were staged or rather classified on the basis of morphology, what we see in microscope. But now they're classified on the basis of molecular rearrangement or molecular mutations they have.
Exactly. And now we have about 400, 500 different targeted therapies that are available, which may be used in place of chemotherapy or with chemotherapy, and which leads to improved outcomes. Now, there's been some advances in the past 5 years or past decade or so. One of the advances is an antibody drug conjugate. So we realized that there were still some situations where while targeted therapy was expected to be effective, was not effective enough and still needed the help of chemotherapy. And we said, how do I ensure that the chemo only reaches the tumor cell, does not reach a normal cell? And therefore, how do I ensure that not only I reduce the side effect profile of the chemotherapy while maintaining the benefit of the chemotherapy, and how do I ensure that I am able to give more cycles of chemotherapy instead of limiting to 6 to 8 cycles that we usually are forced to? And this led to development of a new molecule called antibody drug conjugate. So this is a targeted delivery of chemotherapy. And in certain cancers, you'll not believe it, within 5 years of their development, they are now the first line of therapy, especially for advanced cases. And the last bit of the piece is immunotherapy. Now, our immune systems are very active. And I feel that a lot of us would have cancers which are never diagnosed. They never grow because our immune system would have recognized that a cancer or a tumor is growing and would have eliminated it. And research led to this realization that a lot of cancers grow because they are able to suppress our immune system. And therefore, there have been various strategies which are being investigated to understand how do you reactivate that cancer suppressed immune system so that it's our immunity which kills the tumor or kills the cancer cell and leads to a response, leads to a positive outcome. One of them was this drug called immunotherapy. In fact, it's not one drug. There are multitude of different drugs which neutralize the cancer-mediated suppression and lead to immune cells killing the cancer. And there is a lot of usage in lung cancers, in head and neck cancers, in melanomas, in cancers of the liver, kidney, etc., etc. In fact, the initial usage came in stage 4 cancers where we realized that immunotherapy alone or in combination with chemotherapy led to improvement in outcomes. There was one paper which actually showed, and we've since seen similar results, that the combination of immunotherapy with or without chemotherapy actually led to 20 to 25% people surviving beyond 5 years. And we talked about that, glass ceiling, where only about 5-10% patients with stage 4 cancers make it beyond 5 years. And now we have about 20-25% patients making beyond 5 years. In fact, a potential small number of patients getting cured of cancer. And I think this has revolutionized the way we look at cancer and its treatment. And the next logical development has been the CAR T cell.
Thanks, Dr. Devavrat, for your words of wisdom. It is really a great session. Boon for our viewers to know all these things in such a nice and simple manner.
I'd like to thank you once again for taking this initiative of empowering our audience, our viewers, our listeners in taking control of their health. So thank you for having me here.
It was great and interactive session on oncology with Dr. Devavrat. In a world where cancer claims 1 in 6 lives globally, early detection through screening is our major hope to fight against cancer. By timely screening, awareness, and vaccination programs, we can save countless lives and bring brighter, healthier future to this world. Thanks to all viewers and listeners of this podcast. See you in the next episode. Until then, stay healthy, stay wise, and we at Tata MG will bring care to your health.